Good morning, good afternoon, good evening to everyone. We will get started in just a few minutes. We're going to allow a few minutes for everyone to join, work out any kinks with connecting through Zoom, and then we'll get started in just a few minutes. As you join, I invite you all to please introduce yourselves in the chat. Please write your name, your organization and title, perhaps the country that you're joining us from today. We'll give everyone a few minutes to do that, and then we'll get started officially. This is great. I'm already seeing Ethiopia, Bangladesh, Washington, Sudan, India. Welcome, everyone.
This is Julie, the interpreter. I still don't have the channel. Can anyone assign me, please?
Thanks, Julie. I think our team is working on getting those channels set up while we let
Okay, but
everyone
at least
else
we have
join.
one covered, so we can start. But I
Great.
cannot.
Great.
Thank you.
All right, great. So I'll start again here. Good morning, good afternoon, good evening, everyone, and welcome to the USAID Health System Strengthening PACE Competition Winners Showcase. We are hosting here, I'm with the Health System Strengthening Accelerator. Please, if you've just joined and didn't hear me say this before, please introduce yourselves in the chat. It's fantastic to see so many colleagues joining from all over the world. So please tell us your name, the organization you're with, the country you're joining us from today. So thank you for continuing to do that. Another logistics item is please look at the bottom of your screens. You should see a globe icon. Please go ahead and select that now and select the language of interpretation that you would like. Most of the presentation will be done in English, but please go ahead and choose English in case we have any speakers speaking French or Ukrainian, offering interpretation for those three languages, English, French, and Ukrainian. You should be able to click the globe and then click your choice of language. The other logistics item is for the francophones, pour les francophones là-bas, bonjour, bienvenue. We are going. I'm sorry, say that again. Okay, great. So for the francophones, we are putting a link to the French version of this presentation in the chat, so that you can follow along the slides in French if you prefer to do that. And finally, as we go through this, we'll have a very large group and we'll have presentations by the winners, but we would like to try to mix in as much questions and answers and comments as possible. We will have some time toward the end for a bit of discussion, but please do use the chat to put in questions or comments that you may have about the presentations. And we're going to try to have about 10 minutes after each presentation for some Q&A, and then some time toward the end for a little bit more general discussion. So please don't be shy on this Monday morning or afternoon, and put your questions in the chat. Okay, great. So with those logistics covered, we are very pleased to welcome you to this Winners Showcase event for USAID's second Health System Strengthening Case Competition. My name is Nathan Blanchette. I'm a Senior Program Director at Results for Development, or R4D, and I'm currently the Project Director for the Health System Strengthening Accelerator. It's been my and my team's great pleasure to collaborate with USAID Office of Health Systems over the past 2 years on this case competition, and I think you'll see that this year we had a great amount of growth, which has been very exciting. So we will start today with a note of welcome from the Office of Health Systems. I will then introduce the winners, and the winning teams will then present their cases, and they'll each have 10 minutes to present, and then followed by several minutes of Q&A. The order of the presentations was just determined alphabetically by the submitter's last name. And then following all three presentations, we've also set aside some time to talk about, to have a more general discussion about future learning on health system strengthening. So with that, it is my great pleasure to introduce the Deputy Director of the Office of Health Systems in USAID's Global Health Bureau. Thank you very much for joining us, Tara Simpson. Tara.
Thank you so much, Nathan. Good morning, good afternoon, or good evening to all of you. My name is Tara Simpson, and I recently joined as the Deputy Director of USAID's Office of Health Systems. It's a true pleasure to be with all of you this morning. Thank you so much to everyone for joining us today for the USAID Health System Strengthening Case Competition Winners Showcase, supported by the HSS Accelerator. This was our second HSS case competition, and we were thrilled to see a range of submissions representing work from all over the world. This year, we had over 100 submissions from a wide array of partners showcasing work in 31 countries. This competition is an opportunity for USAID partners working on health system strengthening activities to showcase their work and to highlight the evidence and learning being generated by HSS programs and activities. The learning and evidence from the cases submitted will contribute to our evidence synthesis under the agency's HSS learning agenda, helping to advance the agency's global health priorities and to ensure that solutions aren't designed to target only single diseases or health issues, but instead are designed to address the systemic issues that can impede or improve the delivery of equitable and high-quality healthcare for all. The HSS Learning Agenda has 6 thematic question areas. This year's case competition was focused on 3 of those. In particular, the first one was, how have systems thinking approaches and tools been incorporated in activities to improve health quality equity? Were these approaches useful in achieving health equity goals? If so, what are the pathways by which these approaches helped to address the root causes of inequity? The second one was, what are effective and sustainable mechanisms or processes to integrate local, community, subnational, national, and regional voices, priorities, and contributions into health system strengthening efforts? And the third was, what types of social and behavioral changes or outcomes are commonly sought within the health system strengthening projects or interventions? How are SBC methods useful in creating behavior or norm change among government, private sector, and community health system actors? What are lessons learned regarding explicitly incorporating SBC approaches within HSS programs? We are thrilled to hear from our 3 winning cases, each highlighting one of the themes that I just mentioned. The evidence and learning from these cases will inform and improve our collective ongoing work in HSS, and will contribute to our efforts to strengthen the global HSS evidence base. We plan on holding another case competition in 2024 to continue to highlight our collective HSS learning. I want to thank everyone who has made this competition possible, from those who thoughtfully prepared submissions, the HSSA staff who organized the competition, to the judges from HSSA and USAID who reviewed the submissions and selected today's winners. I will now turn it back to you, Nathan. Thank you very much.
Thank you very much, Tara. And I want to just continue to say some words about what we saw from all of the submissions with the cases this year. So we had really fantastic examples, content on all 3 of the learning questions that were identified. And this year we received 102 submissions. That was a 4-fold increase from the first year last year. And you can see some of the stats here. We had 43 submissions on equity, 47 on locally led development, 12 on the use of social and behavior change approaches. We didn't tally all the numbers, but you can see on that left-hand box the great diversity of health challenges that were covered. So in that list, I won't read them all, but if you scan that list, you'll see virtually every priority health condition that USAID prioritizes. You'll also see several of the health system building blocks or approaches, depending on your framework of choice. And some of the more recent, cutting-edge, innovative topics such as digital innovations. And I think this shows that we really are a community that's dedicated to health system strengthening, but we are doing approaches that really cover the entire gamut of health priorities that we all and with USAID focus on. Next, you'll see a great geographic diversity across 31 countries. So those are listed there. And finally, just to recognize everyone in this community, we had actually 30 different USAID partners that submitted a case, and we have listed all of those there. I want to say on a bit of a personal note, having experienced and helped guide this competition over the past couple of years, the hardest part, of course, is choosing only 3 winners to showcase in this event. We have a limited amount of time, and I think it helps motivate us all to do that. But I also hope that we all view this particular event as only the tip of the iceberg. It's a very impressive tip of that iceberg, but there is a ton of really great learning, system strengthening approaches that are being used, outcomes and results that really matter for people around the world. We are going to try to make all that content as accessible to everyone as possible via our website. And we'll be sharing the link to the case competition This year, we have allowed for some easier sorting by health topic and country. So we really recommend everyone take some time to go there, and really very sincere thank you to everyone for participating, for all the organizations and all the individuals represented here. And we hope everyone will continue to grow this in the third year coming up. Okay, great. So we will go to the next slide. Let me explain that we had a very robust judging process again this year. And I want to particularly thank our 4 expert judges, Dr. Amma Pokuafeni. She's a senior research fellow at the Institute of Statistical, Social, and Economic Research at the University of Ghana. Dr. Lizelle Lagrada Rombua. She's an independent health financing and governance expert and the former head executive of the Philippine Health Insurance Corporation. Dr. Kamalia Mohammed No, professor of public health and community medicine at the University of Sabarjaya and former head of the primary healthcare section of Malaysia's Ministry of Health. And finally, Dr. Helen Saxenian, independent health economist and formerly of the World Bank. These judges worked very hard to judge all of the submissions and deliberate them on them, make recommendations, and in cooperation with USAID, we're able to choose the 3 showcase winners for today's event. So without further ado, I'm very happy to announce here the 3 winners for this year. And their cases are called Integrating Community Structures for Effective WASH Behavior Change, a cross-sectoral approach. Then SafeMed and the Affordable Medicines Program in Ukraine, reducing inequities in medicines access. And finally, institutionalizing community-based drug rehabilitation in interlocal health zones in Leyte province. So congratulations to all of these teams, and we're very happy to hear from you today. Thank you for the applause. Great. So I'm very happy now to turn it over to our first team to present, and I will let the lead presenters and authors introduce themselves and their team and go on to the presentation. So please, the model for cross-sectoral partnerships for sustained healthy hygiene behaviors in Chhattisgarh, India. Please go ahead.
Thank you, Nitin. Good morning, good afternoon, and good evening from India. I'm Pallavi Kumar. I'm representing USAID Nishta project currently being implemented by Chapaigo. Today, I will be presenting a model on cross-sectoral partnership for sustained healthy hygiene behavior. And author for this particular intervention are Pallavi Kumar, Praful Sharma, Pratiksha Pal, Gaurav, Pritika Mulli, Dr. Ashish Srivastava, and Dr. Neeraj Agrawal. And the contributor are Dr. Anuradha Jain. She is the AOR for USAID Nishta project, and our local implementing partner Samarthan. But before going into the case study, I would like to talk briefly about who we are and what we do. So Nishta is a health system strengthening project currently being implemented by Chapaigo across 12 states of India. And our vision is to revolutionize and reshape primary healthcare to provide it more equitable, sustainable, comprehensive, and client-centered approach. Next slide, please. So through this intervention, we try to answer some of the critical questions. So how and what type of social and the behavior change and the outcome are commonly sought within the health system strengthening project. We also try to address what are the different social and behavior methods useful in creating behavior and social norms among the important key stakeholders and the community health actors, and what are the lessons learned regarding incorporating SBCC approach within the health system program. Next, please. Through this intervention, particularly this intervention has been implemented in 2 tribal-dominated districts of Chhattisgarh, and these districts have high population of marginalized and vulnerable population and hard to reach area. Because this is mostly tribal dominated population, they have their own cultural and social norms and behaviors. So through this intervention, we try to expand the reach and impact of healthy hygiene behavior in terms of addressing the social barrier and the cultural barriers towards the healthy hygiene behavior. So the objective of this particular intervention has been forced to bring all the important key stakeholders on the same platform and talk about their shared vision for enhancing healthy hygiene behavior through building cross-sectoral partnership. The second, we focused on how to tap the community structure for local level planning and also taking them action about their health and wash priorities. And third was to demonstrate the impact of social and the behavior change component for enhancing knowledge, attitude, and also involving the community to disseminate information about healthy hygiene behavior. Next, please. So as you know that this particular intervention is for the health system and strengthening project. So we try to address not only the strengthen the demand side, but also look into the supply side aspect of things. The first activity, what we did was identification of geography, and this geography was identified based on the consultation with the important key stakeholder, both from the government side and the community side. The second intervention, we focused on the micro-resource mapping of the important key stakeholder at the government level, at the community level, and also who are the key decision makers. So we try to map them. As in India, we are having different departments who are responsible for improving health and wash services or the facility. So we also did a kind of a mapping of what are the important government resources and the financial allocation within these resources. Once this micro resource mapping was done, the focus was on capacitating the community structure about what are the different entitlement they have, what are the different facilities the government is providing under various schemes, and also equipping their skill on the local level planning, taking the decision, and also mobilizing the resources available under different grants. After that, a lot of community action and the community intervention has been carried out in order to empower the community on the healthy hygiene behavior, particularly focusing on the COVID appropriate behavior, and also incorporating SBCC as integral part for the demand generation. And as I mentioned that in India, there are different departments. So we also worked on making a convergence between different departments who were responsible for different schemes for health and wash component. So we coordinated with the health and family welfare department, department who were responsible for drinking water, sanitation, and other. And through this intervention, we try to reach out to 100,000 people live. Next, please. So in terms, if I talk about the larger impact and the activity, we have seen there has been a lot of impact. If I talk about the social and the behavior change thing, so the community were aware about their behavior. They also were updated about their different methods, how they will be promoting the healthy hygiene behavior. So one example is creating the hand washing corner. So community has come and created hand washing corner, not only at the community level, but also encourage that practices at the household level. So one was to creating the infrastructure and also about how to make them practice and sustain that activity. Second piece of work, what the impact has shown on the creating the local ownership from the community. So one of the example where the community-led monitoring mechanism has been established, where the different partners has come together and work on improving the sanitation. So one of the intervention which the community came and took it forward was the color coding of the sanitation services and mapping those and taking corrective action together with the community to improve those sanitation solutions. The third was on, as this particular intervention was aimed on marginalized and deprived community, and focusing on addressing the special need of the tribal dominated area to provide equitable care. And convergence and partnership has been an integral component. So through this particular intervention, we saw that this helped in promoting collaboration between different departments such as local government, local implementing partner, community-based organization, not only to pool resources, but also to pool expertise and knowledge and enhance the efficacy of the intervention. And ultimately, for sustaining behavior, the hand washing practices, the sanitation practices, and also the menstrual hygiene practices has been sustained during this intervention. Next, please. And we have a lot of evidence, as I mentioned, that the community has been proactively working on constitution of hand washing units and also the community toilet, because this particular intervention focused on promoting healthy hygiene behavior. So we have seen that through this intervention, the community has been able to create more than 500 plus low hand washing corners established. The community has been able to leverage around 20 million USD for village plan for construction and repair of the wash infrastructure. Through this intervention, we have also tried to empower the community level committees or the community who were functional at the village level for water surveillance, because water surveillance was another component which we focused, like mapping of water sources and testing for the fecal contamination. So this intervention, we also try to kind of build capacity of more than 65,000 community members on different aspects. And ultimately, this particular intervention empowered the community to leverage the fund of across 56,000 USD dollar. Next, please. And these are some of the glimpses from the field. And you can see that one pictures talk about how the tribal community, particularly the women, they came together to create a safe bathing space for themselves in terms of maintaining their privacy and dignity. One picture talk about how the locally developed sustainable hand washing unit was created at the community, not only to teach about the practices, but also to sustain the practices. There are different, as you see from the picture, the community are coming together and working through the sustainability of this project. Next, please. And this particular intervention has been a joint effort, and we have been various actor and the facilitator. For example, we have got catalyst support from the USAID and Unilever, not only in terms of the financial support, but also giving us a vision to work and also supporting throughout the intervention. We worked with a different community platform to enhance coordination, resource pooling, and maximizing effort. We also took the support of the local implementing partner. Here we had Samathan as a partner who helped us in designing and understanding community in a better way, contextualized the solution, and also made a tailor-based counseling tools for the community. And last but not the least, we also, since inception of this particular intervention, we have been working closely with the government, and we have got formal approval for the government, which make the system more workable, and also it's also helped in sustaining this activity. Next, please. And if I don't talk about the challenges, because this has been a community piece, a lot of challenges have been there. If I talk about the limited community awareness, because this particular community has their own social and cultural norms and barriers. So there was a limited understanding about the healthy hygiene behavior, and also there was a lot of gap in the practices. So through our intervention, we try to address those things. As I mentioned, different department responsible for different improvement for the wash. So coordination was a major issue. So we also try to utilize decentralized governance platform which were available at the community level to address this issue. Through tailored training and other tools, we try to address the issues of limited understanding and counseling piece. And through the community intervention, particularly the community-led monitoring mechanism, help us to address the issue of limited community awareness. Next, please. So the lesson learned, what we learned at the end, we learned it's very important to contextualize the understanding or contextualize the solution based on the social norms, the cultural barriers, the geography, and make it an effectively tailoring of intervention. The second piece, if you want to work in the community, ultimately the collaborative effort with the key stakeholder and department are a win-win situation for both for the system as well as the community. And it also helps in pooling the resources, pooling the cross, and also encourage the cross learning. The third was empowering the community structure. So unless and until we don't work with or engage with the local community organization in the decision making, monitoring, and also sustaining this behavior change. Continuous communication and also creating different channel of communication between the community and the general community structure has been key component of our intervention. And we learned that continuous communication is a way forward, and also tailoring the messaging and through multiple channels. Last but not the least, if you want to look at the impact and also the scalability of the model, it's a very, very important to have the monitoring and evaluation built and incorporated at what as a critical component of the intervention. Categorically talking about the SBCC integration, integrating SBCC, because when we talk about the health system programming, it has to be designed in a way that it should be strengthen the demand and the supply side. So in terms of strengthening the demand side, it's important to integrate SBCC component, customize SBCC strategy based on the target population, because we all understand that one size will not fit for us. So it's important to customize and have a tailored approach. And ultimately, for any behavior change communication, bringing together different actors, players is very important for successful SBCC implementation. Next, please. And at last, I would like to mention the donor for this project is USAID and Unilever. We are implementing, Japaigo is implementing this particular project through NISHTA, and our implementing local partner who has provided a lot of insight in implementation and help us to take this intervention forward is Samarthan. So thank you so much, everyone.
Excellent. Thank you so much, Pallavi, for a great presentation. We have a few minutes now for some follow-up questions. And I see a couple already in the chat. So let me just say these, but please, if others have questions, go ahead and put them in the chat. So one question is, what mechanisms and approaches have you used for convergence between departments?
So in terms of the mechanism and approaches, what we have used is like right from the building of intervention and the pre-implementation phase, we have identified who are the important stakeholder or the gatekeeper at the community level. We brought, and we also did a kind of a community consultation with the important stakeholder to understand more about the community, making them a part of the designing process, implementation process, and as well as the monitoring process.
Thank you very much. And I see a comment here, and maybe you can come off mute if you would like. It's Bornwell Chimba. The comment, every important thing is SBCC and local community engagement as it brings ownership of the project. Do you want to add anything onto that, Bornwell? Great comment, or any question, or it's fine as is?
Yeah, it's very important because SBCC will not be successfully implemented without bringing that community ownership, because ultimately we are talking about the behavior change of the community. So unless until the community is itself an important stakeholder in designing of the behavior change, also addressing the social and the cultural norm, it's very difficult to achieve the objective behind it. So I think it's very important for it to get successful.
Great point. There's another one here that combines with a question I had. There's a comment about SBC programming really can't be successful without monitoring. And you mentioned monitoring. Can you say a little bit more? I'm also curious about not just within the project timeline, but what steps, if any, have been taken to sustain that kind of monitoring at the community level in the future?
So basically, as I mentioned, and you also mentioned that the monitoring has to be an integral component while implementing the project. So what we did is like we had kind of a continuous monitoring system. So there are two different kind of monitoring what we envisaged and we did in our project. One was the project monitoring. So we identified few of the indicator which has to be measured over a period of time in terms of seeing the progress. But also because it's a community model, so we also have involved the community-led monitoring mechanism. So it's only not that the project will be implementing a certain progress, but community can also monitor and take corrective midway actions in terms of sustaining this behavior and also sustaining the intervention. So these are the two important aspects what we did in our particular intervention.
Excellent. Okay, let me just pause for a few seconds. Last call for any final question. Apologies if I missed any in the chat, but I think anyone can come off mute if there's any final question. Okay, great. Well, thank you very much, Pallavi and team, and we will move on to our second presentation now.
Thank you so much. Thank you.
Thank you. So thank you very much, and we'll move on to our second presentation. Before this team begins, I just want to say a note of take a moment of reflection and send a message of support from our whole health system community here to this team in Ukraine that has obviously been dealing with an extremely difficult time to be working. But I think that you will be all very impressed by what they've been able to continue to do in health system strengthening despite the very difficult conditions that the current war is presenting. So with that, I'll turn it over to Anna. Anna.
Thank you, Nathan, and thank you for your kind words of support. This means truly a lot for us. Hello, everyone. My name is Anna Bezruk. I'm technical advisor on pharmaceutical governance at the USAID SafeMed activity in Ukraine, implemented by the Management Sciences for Health. And SafeMed is an 8-year project started in 2017, and among other project activities, we have been supporting the government of Ukraine in the rollout of the Affordable Medicines Program that I'm thrilled and pleased to share with you today on behalf of SafeMed, MSH, and National Health Service of Ukraine co-authors that you can see on the slide. And thank you so much for recognizing this important initiative. Next slide, please. So without further ado, the learning question that we focused around was about how systems thinking approaches and tools have been incorporated in activities to improve health equity and the impact and outcomes of the approaches that we used. Next slide, please. Starting from the background and a little bit of context, in 2015, the government of Ukraine spent less than 3% of its GDP on health, below the average of countries in the WHO European region, despite taxing for health coverage. Outpatient medicines have been the largest driver of out-of-pocket payments in healthcare, around 60%, and they were quite high, around 90% spendings. Patients could visit healthcare facilities in the region of registered residents, and regional programs of reimbursement were or absent or ineffective. Next slide. And so the thorough healthcare reform in Ukraine began in 2016. The Medicines Reimbursement Program, also known as Affordable Medicines Program or shortly IMP, was launched later in 2017 under the Ministry of Health Management. SafeMed project, since its creation, has been supporting the government in the rollout of this program. It was designed to cover medicines for chronic conditions based on burden of disease, prevalence, and availability and cost-effective treatments. It started with only 3 directions: medicines for cardiovascular diseases, type 2 diabetes, and bronchial asthma. And SafeMed supported the government in the development and implementation of the best world practices, for example, external reference pricing mechanisms and reverse auction in order to optimize funds and budgets. And in 2019, the program administration was shifted under the umbrella of the newly created national payer, the National Health Service of Ukraine and HSU, together with the huge technological advancements, electronic prescription launch. And after that, the program was constantly growing, as you can see on the roadmap slide, adding new therapeutical conditions and medicines to it. And in general, shortly, the program functions as follows. Family or specialty doctors prescribes the medicines to a patient in the electronic system. The patient receives the code on their phone. At the pharmacy, patient gives the number to the pharmacist, and the pharmacy fills the prescription and dispenses the medicines for a patient for free or with a small copayment. And after that, the NHSU directly reimburses pharmacies for the cost of prescription drugs dispensed to patients. Next slide, please. So what impact and evidence we can observe up to now? More than 4 million patients received medicines under the program from its start. Around $145 million US has been reimbursed since the beginning of the program. The proportion of out-of-pocket spending to total spending on medicines has been reduced from around 90% in 2017 to 66% in 2023. On average, the program led to reduction of in previous copayments to access medicines. And also we observed the increase in the medicines share that are under the program, and which indicates increase in utilization of these medicines that are covered. Importantly, the entire population now is eligible for the AMP and can select the hospital and doctor in any region and use any participating pharmacy in any region, city, town. And doctors state that many new patients come for treatment now, that they could afford medicines and can get them easily and do not interrupt their treatment, which is critically important in the case of chronic diseases. Next slide, please. Moving over to facilitators of the project, we chose 3 of them that were most significant. The first one is legal reform. Multiple legal reforms and documents paved the way for program execution with new regulations to evolve the program. The main milestone was adopting the law on state financial guarantees of medical service to the population in 2017, which followed by numerous bylaws. The second one is technological advances. SafeMed supported the development of the electronic prescription and improved health information system allowed for financial planning, contract development, performance management, and processes transparency. And of course, private sector engagement. Overall implemented program model have stimulated public-private partnerships And the government relies on private pharmacies to ensure medicines availability, fostering a partnership for affordable and accessible medicines. Next slide, please. There were, of course, various challenges along the way, but the most drastic of which was, of course, the full-scale invasion of Russia that is ongoing, unfortunately, that started in February 2022. However, despite all the challenges, the program continues to operate during wartime. The production capacity, retail sales, procurements, consumption of medicines, and overall programs volume throughout Ukraine dropped significantly in 2022, but quickly rebounded in 2023, and the government adapted the program to needs of population fleeing from the occupied territories at the front line. For example, different procedures were easy. Paper prescriptions were allowed as an emergency mechanism, and as a result, what we can see is that actually internally displaced patients were able to receive their medicines without needing a new prescription from a new prescriber. More than 1.5 million patients continued to receive their chronic disease medicines in 2022, which is the most important, of course, NHSU continued to pay and fulfill their contract requirements and paid to contracted pharmacies, and even added new pharmacies after March 2022. And to support the program in wartime, CIFMED embedded consultants to bolster the NHSU IT department operations to continue all the processes and solutions. Supported the development of patient education videos about accessing prescriptions through the program during the war. Offered expanded support through data analytics firm to track impact of the war on the market, on the program, and identify quickly ways to modify the program, and provided just-in-time legal support to draft all necessary needed regulations to ensure patient access. Next slide, please. So some of the lessons that were learned along the way. The first one is tap an underutilized resource by engaging diverse actors. The private sector plays an important role in advancing legal, political, societal reforms in Ukraine, and CIFMED and NHSU regularly hosting biannually reimbursement forums to elicit feedback and steward relationships, to discuss program successes, challenges, and future and expansions and developments. The next one is technological interoperability. CIFMED IT experts worked with NHSU to ensure that their data platforms were interoperable with countries' wider electronic health systems and contained accurate and data that can be used to inform decision-making. Then the other important one is capitalizing on political will. The program would not have been possible without important legislation to pave the way for funding allocation, governmental collaboration, and prioritization. And advocating for legislation and increased annual state budget allocations was an essential part of this program's process and continues to be an important activity. And last but not least is so-called emphasizing action over perfection, value of feedback loops. If the affordable medicines program had waited until every process was perfect, it would have never launched. And so the feedback loops were installed from the beginning to capture data and improve processes for continued efficiency and medicines access expansion. And SafeMed, by hiring the pharmaceutical data firm already mentioned, S&D, helped to analyze market data to inform subsequent iterations of the program and continue to expand coverage both geographically and pharmaceutically. Thank you so much for your attention. We'll be happy to answer your questions.
Excellent. Thank you very much, Anna. And again, very impressive what you and the team have been able to do through this work. So thank you for an excellent presentation. Let me turn now for a few minutes of Q&A, and looking at the chat, I see one comment at least coming in about it being an excellent idea to launch before the program was perfect and instill feedback loops. I really appreciated that point too. Annette, would you like to say anything more about that? Or Anna, does that trigger anything you want to say more about that point that you made?
To be honest, there is not so much more to say, but we recently also discussed that on our reimbursement forum in September, and also all stakeholders really value that the both the National Health Service and government is open to feedback and open to listen to all participants, all stakeholders, and they're really grateful and also valuing this as one of the key successes of the program. Great.
Yeah, very well said. Another comment is particular to the systems in the former Soviet countries. How did you overcome the challenges of the fragmentation that is common in those systems?
Yes, thank you for mentioning that. It is really a huge challenge, especially in terms of legislation that we're facing. That's why the first stage was always to work on the legislation, work to have the basis on that, and to really align all the processes. And that's why, as I mentioned in the presentation, the baseline was to have this law on state financial guarantees, which was around 1.5 years of work of different collaborators to have that law in place, and still it was then adjusted and modified later on, but it was the basis for all other steps and changes, and then all the bylaws that need to be in place to also have the system not fragmented.
Very interesting. If I can add a question of my own, and please, we have a few more minutes, so keep the questions coming in the chat. Question of my own. We are all here with USAID, many implementing partners for USAID. It's sort of a question about how we all do our work and work planning that we have to do with USAID. I was very impressed by the multiple facilitators, you called them, system facilitators. So you had things going on in the legal space, things going on in technological innovation, things going on with how to engage and pay private sector. I'm curious whether all those pieces were sort of recognized from the very beginning, and there was sort of agreement to be working on all of those, or was it more a focus in one space and these other things were just sort of happened to be happening, or was there really a deliberate effort to bring these sort of multi faceted pieces together for this?
Thank you for your question. To be honest, I joined the program, joined the project in 2018, and have been participating in planning processes since then. And it all come to this form in in couple of years. But we always listen to the partners and discussing the bottlenecks and directions of support, of course, and that's why it kind of grew into that format that is existing now, really in like several directions: technological, legal, and stakeholder engagement and communication strengthening, and monitoring, of course, too.
Yeah, that's great. That's great. One of the things that I know the team in the Office of Health Systems at USAID was emphasizing with the vision that they had and this case competition was moving away a little bit from a previous era of us, really focusing on one of the health system building blocks and really recognizing that most of the change that we want to help to happen requires multiple sort of either building blocks or multiple aspects of the system, even beyond the building blocks, really, to happen in concert. So anyway, kudos again for a great leveraging of all that for great results. I see another question from Nilufar. Does this reform affect access and coverage of all types of medicines for all types of diseases, such as infectious diseases, chronic care, pediatric, etc.?
Thank you for your question. If we can go back to the slide with the roadmap to be more visible. So there, as I said, we started with three conditions, and then roll out to more. So it's like 9 conditions now, and like plans. There are plans for expanding within the categories in upcoming year or two. And also recently, the first medical devices were added to the program. So it were insulin test strips for blood glucose test strips for controlling level of insulin, level of sugar in blood. Sorry. And here you can see like all the diseases that have been added. So diabetes, mental health disorders, and epilepsy, diabetes insipidus, and then some combined for chronic diseases of the lower respiratory tract, Parkinson disease, and post medicines for treatment in the post-transplantation period. So all of them are included.
Great. Well, thank you very much. I don't see any more questions in the chat coming in, so I think we can start to transition to our third presentation. Again, Anna and team, thank you very much. Be safe, and thank you very much for sharing your work with us. Great, so we'll move on now to our third and final showcase winner. A case entitled Institutionalizing Community-Based Drug Rehabilitation in Interlocal Health Zones in Leyte Province. And this team knew that they may have poor internet connection during the time that we are having this event right now. So they very kindly and proactively volunteered to video their presentation ahead of time. I believe the team is online with us today, so we can probably talk with them live as well, but just to make sure the presentation goes smoothly, thank you to that team for videotaping it ahead of time. So with that, we will go ahead and start. Thanks. We do not hear the audio yet, MJ.
Okay, 1 second. Let's reshare quickly. Great. Alrighty.
Good day to all. My name is Joy Naputoko, the Provincial Coordinator for Leyte of the USAID Renew Health Project. Presenting with me today is my colleague, Ms. John Marge Nicole Ramirez. Our other co-authors are Mr. Miguel Tongco, Ms. Amihan Perez, and our Chief of Party, Dr. Regina Chanova Alampay. Allow me to acknowledge the presence of Dr. Ofelia Alcantara, former mayor of Tolosa, Leyte, who envisioned the scaling up on implementation of the community-based drug rehabilitation in the interlocal health zone in Leyte province. Also in attendance are our development partners from the Department of Health Eastern Visayas, some of the members of the Technical Management Committee of the Interlocal Health Zone for CBDR and Mental Health. Highlights for our case presentation will be based on this key learning question. What are effective and sustainable mechanisms or processes to integrate local, community, subnational, national, and regional voices, priorities, and contributions into health systems and strengthening efforts? Now imagine what it's like in the Philippines in 2019 in the midst of the government's war on drugs. You have about 1.3 million drug-involved persons, with majority needing community-based drug rehabilitation in a country that treats drug use a crime and with no history of community-based drug rehab. How do you build a health system that enables delivery of evidence-based and compassionate community-based drug rehabilitation in low-resource municipalities? This was the challenge of the USAID Renew Health implemented by the University Research Co. The project seeks to expand access to compassionate and evidence-based drug rehabilitation in communities. Community-based drug rehabilitation, or CBDR, is an integrated model for helping persons who use drugs or PWODs with low to mild severity of use. It includes screening, treatment, recovery, and family support, aftercare, and reintegration. The main goal of USAID Renew Health is to help PWODs, people in recovery, and their families obtain access to informal care, self-help, or community-based rehabilitation and recovery support to reduce or prevent drug dependence. The Dangerous Drugs Board projected that about 90% of persons who use drugs are low to moderate risk and can be treated in communities. There are about 1.18 million Filipinos needing treatment. However, a baseline study conducted in 2019 showed that only 15% of PWODs receive appropriate treatment. In addition, there's a lack of trained human resources, lengthy treatment, and lack of evidence-based treatment appropriate for clients' risk level, and lack of resources. This led the province of Leyte to send their PWODs to the Lone Treatment and Rehabilitation Center in the province run by the government. To model CBDR in a low-resource setting, USAID Renew Health partnered with the municipality of Tolosa, whose mayor Ofelia Alcantara was a doctor, who firmly believed the importance of treating substance abuse using a healthcare lens. A needs assessment was conducted that validated that 94% of clients were low and moderate risk. Tolosa adopted the community-based programs for PWODs developed by USAID Renew Health and Psychological Association of the Philippines. Service providers within the municipality were capacitated with CBDR competencies on outreach, screening, and program delivery. The success in Tolosa prompted Dr. Alcantara to suggest the expansion to nearby municipalities also struggling to deliver CBDR services. In 2022, the ILHC model for CBDR implementation was presented to the Department of Health Eastern Visayas, the Provincial Health Office, and to the representatives of the municipalities of Golden Harvest and Leyte Gulf interlocal health zones. A series of meetings were conducted to revitalize two interlocal health zones of Golden Harvest and Leyte Gulf within the Leyte province. A technical management committee was activated, and an ILHC resolution was created adopting CBDR, as well as another policy creating a technical working group to operationalize the CBDR program for the ILHCs. To prepare the ILHC-wide implementation, numerous meetings and courtesy calls were conducted by the project with stakeholders involved. Several capacity-building activities for service providers were also conducted to enhance service delivery and enable collaboration among 8 municipalities. My colleague Nicole will now present the outcomes and challenges we experienced.
Thank you, Ms. Joy. This is John Marge Nicole Ramirez, Field Officer of USAID Renew Health Leyte team. Now, I would like to emphasize the impact and evidence of the work carried out by the USAID Renew Health project. As of March 2023, we are happy to share the significant results achieved by the Interlocal Health Zone. Currently, all 8 municipalities within the Interlocal Health Zone are equipped to provide various CBDR services from reaching out to PWOODs and their families. Because of the increased capacity, we have successfully reached 50.54% of the estimated total number of PWOODs through the use of social behavior change communication materials and activities. Of those reached, 91.34% were screened. Out of those screened, 75.37% were enrolled in CBDR programs, and 80.66% of them successfully completed the program. However, the journey has not been easy. Initially, the challenges was the absence of evidence-based program. To address this, formative research was conducted to assess the needs of municipalities within interlocal health zones, and pilot-tested interventions suitable for PWOODs were developed. Another challenge was the presence of stigma and discrimination. To combat this, capacity building of service providers was enhanced, and positive social behavior change communication materials were developed. Lack of trained personnel was also identified as a challenge. To overcome this, a pool of trainers composed of Rural Health Unit or RHU personnel, such as physicians, nurses, medical technologists, midwives, barangay health workers, and barangay health emergency response team was created, and permanent local government unit staff were trained to ensure sustainability. Furthermore, the burden on healthcare workers was a concern. To alleviate this, social workers, barangay health workers, allied health workers, barangay anti-drug abuse councils or BADACs, civil society organizations, and even faith-based groups were provided with training to support the existing workforce. However, there were also a number of enabling factors that played a crucial role in the successful implementation of this ILHC model. First is the presence of a dedicated advocate for community-based drug rehabilitation in the form of Tolosa's very own Dr. Ofelia Alcantara, who served as a strong champion for the cause in Tolosa. Second is the active presence of both Leyte Gulf and Golden Harvest ILHZs, which provided a conducive environment for the implementation of the project. Third is the unwavering support from the Regional Office 8 of the Department of Health Eastern Visayas Center for Health Development that played a significant role in ensuring the success of the initiative. Next is the issuance of guidelines and directives by the Department of Health regarding the implementation of CBDR, which provided a clear framework for the project's execution. And lastly, the collaboration and partnership with civil society organizations which brought additional resources, expertise, and community engagement to the project, further enhancing its effectiveness. Though the project is still ongoing in the ILHZ, allow us to share the following lessons we have learned while implementing this activity and how will this impact future activities or approaches. First, the strong and strategic partnership of government, academe, civil society, and religious groups help implement CBDR. We always work with our government stakeholders, including their CSO partners, in capacity building efforts. Second, aligning activities with existing government policies ensures support. Cognizant of existing policies and contributing to the discussion of formulating policies ensures buy-in on both the national and especially the local level stakeholders. Third, to address stigma, it is important to educate community stakeholders, such as local officials, community members, and family members to provide the enabling environment. Formative research was important in helping craft alternative messages. Fourth, the whole-of-nation approach holds true at the local level. In the context of the ILHZ, it is essential to pool resources and foster a unified commitment to effectively address drug-related issues. And lastly, consistent monitoring and evaluation with accurate data are essential for assessing effectiveness, making evidence-based decisions, identifying gaps, promoting accountability, and ultimately improving the overall impact of programs and interventions. Although CBDR in the country is still in its infancy, we are happy to say that it works, and an interlocal health zone model is a promising model in low-resource settings. We are heartened that our project has also been recognized by our Department of Health, and more importantly, that our government is now recognizing substance use as a health issue. And that ends our presentation. Thank you all for listening. Maupay nga adlaw ha iyo nga tanan. Good day to you all.
Thank you very much, Nicole and David and team, for that great presentation. which was right on time since you videotaped it before. I want to give you, if any of you are online right now, just the chance to come off mute, video if you would like, to say anything additional or just introduce yourselves. Is one of the team online with us?
Hi, Nathan. We are actually all online. Even our local partners are here. So we'd like to thank the department. So guys, if you want to open up your cameras and mic, including Doc Marvin, please do so. We'll be happy to answer your questions.
Excellent. Thanks so much. I'm so glad you're able to join us, and the connection seems okay. It was a little choppy at first, but then it got better. So great. Okay, great. I see Nilufar, I don't know you, but thank you very much for all these great questions that you are asking. Please keep it up. And others, please add some questions in the chat. So Nilufar asks, you are highlighting an importance of champions in health systems. How did you identify and empower such champions?
So I'm going to answer that on behalf of my team. When the drug war began and there were thousands of people being killed, and the government now was trying to advocate the use of, that really came up was church to work with who were willing to work on the ground. And what we tried to do is understand where they're coming from and how we could help them deliver, what can be very complex matters like cognitive. How do you do cognitive behavioral therapy if you're a paraprofessional? So we really use human-centered design thinking in developing our approaches and in developing our materials. We try to make sure, for example, that our materials are very, very user-friendly, accompanying videos, accompanying manuals and flip charts to make it very easy for our partners to deliver the program. We actually also had to translate and make sure that the dialects that we are using in the materials are local dialects. We even had to, for example, there are two major religions in the country, Christianity and Muslim. So even our manuals recognizing the importance of spirituality as a recovery capital in the country, we try to embed that in the program as well. So yeah, just trying to understand the culture and the context from which our service providers and champions are coming from. And my team, if you'd like to pitch in, please go ahead and just open your mic.
Yes, no, in very difficult circumstances. Thank you. Let's see. This is a comment, but let me just vocalize it. And if you want to comment more, please do. Annette is saying she really appreciated the use of data and also enjoyed reading about the multi-pronged approach to stakeholder ownership, from the DOH to CSOs and in between. Do you want to say anything more about either the challenges or opportunities with such multi-stakeholder engagement?
It was very interesting to me to see the other projects actually also had very similar challenges, right? Fragmentation, especially among in government partners. And so that's not necessarily unique to the Philippines. And I think it's really finding the right mechanisms, perhaps, that play a role. I'm wondering if Doc Marvin would like to open his mic and say something. So we were just talking about how they themselves, the Department of Health, have sort of strategies in terms of handling the fragmentation in how community-based drug rehabilitation is implemented. I don't know if his signal is good, but maybe we can move on to another question, perhaps.
Great. Yeah, I'm not sure if he's able to hear that or come up mute. Was that Miguel that you were referring to, or someone else?
Yeah, it was Doc Marvin from
Doc
the
Marvin.
Department of Health.
Ah, okay. Oh, that's okay. Do we have any
Yeah.
other questions? Okay, he says his signal is poor. He was hearing us but can't come. No problem. Okay, so actually with the time that I see is remaining for us, I think let's wrap up the Q&A for this final presentation, and we'll just go into some general discussion for the end here. First of all, please give the speakers either physically or with your emojis a big round of applause. Thank you for great cases and great presentations. It's not easy to always summarize and synthesize the kind of work that we do in a very short amount of time, just 10 minutes, just a handful of slides. We certainly lose a lot of the richness, we know, but you all did a great job in representing that very well. So we just have a few minutes left, and I wanted to first give a little bit of a reminder from last year's case competition. We actually had a poll where participants ranked learning priorities to gauge the impact of health systems thinking on health outcomes in their work. So we wanted to sort of show this to everyone and continue to reflect on it. We haven't done a similar poll this year, but to understand sort of what some of the priorities were from last year. And we did ask our speakers to think particularly about the first question that had come up there. So let me vocalize that and then maybe turn back to a few speakers to see if they have some comments on this question. The question is, what kind of pre-implementation strategies have effectively paved the way for scaling up initiatives? I think it's referring to some of the very early steps that we might take, engaging with stakeholders, planning work, strategizing about how to sequence things, what factors to emphasize, which ones to emphasize less, all of these sort of pre-work that we all do. Which of those kinds of things seem to be most effective for some of the institutionalization and scaling up of some of these initiatives that we're seeing? I don't know if maybe we could go in the same order, or if we have a volunteer. Actually, I see Pallavi, you're first on my video screen, so I wonder if I could call on you for that question.
Thank you. So if I talk about the pre-implementation strategy, which has effectively paved our way in scaling up intervention. So two of the important aspects, what we factor in while designing and also in terms of pre-implementation stage, was the early buy-in from the government, which included not only in the process of designing, but also in identifying the geography and sustaining the activities. So that has been one of our key strategy in terms of how best we can scale the initiative. The second thing is the formative assessment and consultation with the key stakeholder, because that also built up and helped us in designing our intervention. So these are the two important learning we have that should be an integral part of the pre-implementation strategy while we think of scaling up this initiative. Thank you.
Great point, Pallavi. Thank you. Anna, could you go next?
Sure. From our side, I think also that's reflected in other participants' presentation. I think it's understanding like stakeholder mapping and understanding who are the collaborators inside the or country, if it's like governmental all over the country activity or intervention, or local, more like regionally placed collaborators. Of course, analyze bottlenecks and landscape the legislation that is in place or should be in place. Yeah, and I think that's from my experience, it's kind of what can be very helpful.
Thank you very much, Anna. And Regina, perhaps if you're still able, would you like to come in on that question, or someone else from the Philippines team?
Yes, hi. I'm Mihan Perez here. I'm gonna answer that first question.
Great.
Well, for our team, I think it's the selection of our local partners that is one strategy. As we were saying, it's also related to the other two speakers. It's the identifying of partners. So, in our case, it's selecting the low-hanging fruit, as our chief of party was saying. So we selected a small town in Leyte province because the chief executive wanted to be part of the project and already had the vision for community-based rehabilitation in her locality. And she eventually became the champion for the area and for the other municipalities. And then we all started by doing our initial consultation meeting just to make sure that the stakeholders had buy-in for the initiative, and that this consultation meeting was in partnership already with the regional department of health. So I think in terms of pre-implementation strategies, that's what really worked for us. So thank you.
Great point, and all these points really resonate with me a lot too. I'll make with a smile, I'll make a plea to USAID from all of us. I think you'll see that when it comes to implementing these projects, we have found that getting a little bit more time for a first phase of scoping and stakeholder engagement can be just so effective. In the talking about the brass tacks of our project cycle and management, we have had a lot of success in sort of agreeing on a bit of a first phase. It might be at minimum 3 months, sometimes if you have the luxury of 6 or 9 months, just to be doing this kind of identification of champions and consideration of best starting points, etc. I would say that anytime that there's a possibility of working that into our planning and implementation phase, it seems to really pay dividends richly. So great. We're just about at end of time, but I am grateful for one of our participants, Nilufar, for asking some great questions today. And I see you have ended with a good comment too, about the connection you saw across all 3 cases. I'm wondering would you like to come off mute and vocalize that point, Nilufar?
Yes, sure. Yes,
Go
thank you,
ahead.
Nathan. Thank you very much for organizing this competition. I'm so excited. We have been submitting ourselves for 2 years. We're not losing the hope. We'll continue doing that. But what I want to say is that, I work for USAID and I've been implementing USAID projects, and most of the projects are focused on specific disease areas. But the nature of this 3 cases, they cannot just focus and work with one specific stakeholder. They need to work with multiple stakeholders, and they need to bring this kind of interconnectivity, commonality. I think that the first presenter, they use this word convergence. Many others, they use the word partnership, coordination, and there is no one formula for that. This is still unexplored. That's why, I think that health system is often some sort of a black box. You can't write a standard operational protocol on how to do health system strengthening. But one thing that is clear is that the health systems project, they build interconnectivity. They bring together the stakeholders that normally may not work around the common aim, and they build this momentum and changes. So kudos to you all, and thank you for letting me share this comment.
Wow, that's brilliant, Nilüfer. Thank you so much. And really that's a great comment for us to conclude on. So thank you very much. And Tara, thank you for your reply in the chat that you hear us. And I know you do. I know you all believe in that too, in terms of those key early design and implementation steps that we take together. So thank you very much, everyone. We've come to the end of our time together today. Congratulations again to the 3 showcase winners, but also genuinely congratulations to everyone. Nilüfer, don't give up hope. We're not giving up hope either. That will be highlighted in the future. But really, I hope everyone does take some time to go to the website, sort by some of the topics and countries that you are most focused on, and check out some of the other cases. There's really so much that could have also been highlighted, and we're just limited by the amount of time here. So please do that. Thank you again to USAID and the Office of Health Systems for sponsoring this competition. We're all very much looking forward to the 3rd year of it. The Health System Strengthening Accelerator project that I lead has the privilege of supporting that for a 3rd year, and we will be communicating with the whole community very soon about the timeline for that and any tweaks to how we do the competition. If anyone has suggestions about that, by the way, please feel free to let us know, and we'll share your feedback with the USAID team that we work with to organize this. And let's see, website. Have we put the link in the chat? Does everyone have that? If not, we will. Yes, there it is. Thank you, Amanda. So the chat is there. I believe we will also be sharing the PowerPoint slides, and I think the video that was shown. Apologies for some of those black dots that showed up. So thank you very much, everyone, and I hope you have a great rest of the day. Everyone stay safe and continue the great health system strengthening that you're all doing. Thank you.
Everyone.
Thank you.